Hello doctors, welcome to our NEET Medicine Recall session. So I am Dr. R. Karthikeyan, MD Medicine from MAMC Delhi. So today we will discuss the medicine MCQs which are asked in NEET with full of pictures which will improve your pictorial memory and will also make you fall in love with medicine. Let's start it. First question, a 30-year-old female came with complaints of palpitations and fatigue. On auscultation, a mid-diastolic murmur is heard. So a JVP is elevated and a prominent A wave is there. What is a possible diagnosis? MS, MR, TS, TR. So for this, we should have a proper understanding of JVP first, so that we can easily correlate with clinical findings. So let's see the sketch of JVP. First, this JVP is the reflection of the right atrial pressure which is transmitted to the jugular veins. So first, in the cardiac cycle, if you see, S1 followed by a systole where the ventricle contracts, and then S2, and then followed by ventricular relaxation, which is the diastolic phase. In the diastolic phase, if you see, first phase will be the blood in the atrium will be filling rapidly downward into the ventricles, and the last phase of diastole, the atrium will actively contract to empty the blood into the ventricles. This active atrial contraction produces a positive wave in the JVP, which is A wave. Okay, so in the last phase of diastole, A wave happens. Next, what happens? The tricuspid valve closes. Now, next what happens is the right ventricle starts contracting. In this time, when the pressure increases in the right ventricular cavity, this pressure pushes the tricuspid cusp upward. That has a small positive deflection in the JVP. This cusp wave is called C wave in JVP. This is also positive wave in JVP. Okay. Next, what happens? The right ventricle contracts actively. So what happens is the tricuspid valve will be pushed down because the right ventricle is contracting actively. So the atrium, now if you see, the volume of atrium is enormously increased. So pressure will be automatically reduced. So decrease pressure, fall in the JVP. This produces a negative deflection called X descent. Relaxation of atrium, X relax, X descent. Next, what happens? The atrium will be starting to fill by the blood from the jugular veins, SVC, IVC, all these things. So when blood starts to fill slowly, at one point of time, atrium will be completely filled up. After that, blood starts to accumulate in the JVP, jugular veins, producing a positive wave, which is the V wave or the volume wave. Why am I telling volume wave? Because this V wave will be significantly increased in hypervolemic states like CKD, congestive heart failure, all these patients. Then what happens? This is followed by our S2. So now what happens is the atrioventricular valve, tricuspid valve opens. All the blood accumulated in the atrium falls rapidly into the ventricles. Rapid emptying happens. So when this emptying, pressure falls in the right atrium, negative descent is produced in the JVP, which is the Y wave. You can remember like empty Y has Y descent in JVP. At last followed by active atrial contraction, which is the A wave. Yeah. So now I need to know where are the prominent A waves in JVP. See, first thing is, whenever the atrium contracts vigorously, strong atrial kicks will produce prominent A wave. So there should be obstruction in some part of the tract so that prominent A waves are produced. If tricuspid valve is stenosed, then strong atrial kicks will happen, producing prominent A wave. Or any right ventricular outflow tract obstruction, like it may be a pulmonary embolus, pulmonary hypertension, pulmonary stenosis, where the outflow tract is narrowed. So there right ventricle undergoes hypertrophy and it can't dilate properly to receive the whole blood from the atrium. So now the atrium should contract vigorously to push the blood from the atrium to the ventricles. So any cause of increased right ventricular end diastolic pressures, or even left ventricular outflow tract obstructions like aortic stenosis, HOCM. What they will do is, due to the hypertrophy of the septum, it will compromise the right ventricular cavity. So automatically right ventricular cavity is diminished. So the right atrium should pump effectively so that blood comes from the atrium to the ventricles. So also in LVOT, like left ventricular outflow tract obstructions like AS, HOCM, you can see a prominent A waves. So all are the causes of prominent A waves in JVP. So the answer to this question is definitely tricuspid stenosis. Okay. Yeah. A 50-year-old man came with complaints of cough and chest congestion. It's a known case of atrial fibrillation. On examination, he had irregular pulse, and ECG showed atrial fibrillation with controlled ventricular rate. He has been on potassium chloride, triamterene, and clarithromycin atenolol, and his serum digoxin levels were found to be increased than previously. So which of the following medications among these can cause elevation of digoxin levels? So here, if you see, actually there is a reasonable explanation for the answer, but still, if you are applying your logic here, you can actually rule out all the three options and you can go with single clarithromycin option. Let's see why. First, for digoxin toxicity to happen, what is its relation with potassium? Let's see this. First, if you see digoxin's mechanism of action, as we know, sodium potassium ATPase is there. Digoxin will inhibit this sodium potassium ATPase. Everyone knows this. But where does this bind to inhibit this sodium potassium ATPase? It binds at the potassium site and inhibits this sodium potassium ATPase. Simply, if we want to tell, digoxin and potassium compete with each other in binding at this K-bind site. So just think now, in case of hypokalemia and hyperkalemia, what will happen? If potassium levels are very low, what will happen? No competition from potassium, digoxin will occupy all the sites of sodium potassium ATPase. Digoxin will load calcium into the heart, causing digoxin toxicity. And if there is hyperkalemia, what will happen? Lot of potassium is there. They will drive out all the digoxin away from the sodium potassium ATPase. So this will cause therapeutic failure, drug failure. Digoxin won't work in these patients. So let's see among the given drugs any relation with potassium values. First is our triamterene. Triamterene, as we know, it is a potassium sparing diuretic. Okay, so it causes diuresis with potassium sparing action by inhibiting the ENaC channels in the distal tubule, collecting ducts. So potassium will increase after giving this drug. Okay, next, atenolol. Atenolol, if you see, it is a beta blocker. It inhibits beta receptors on the renin-angiotensin-aldosterone axis, RAS, renin secreting cells in the kidney, JGA apparatus. It inhibits the beta receptors on that cells. So RAS system is not activated, aldosterone is not functioning. Aldosterone's action is sodium water retention, potassium secretion, proton secretion. Potassium is not secreted out, so that will lead to hyperkalemia. So, and also we are giving potassium chloride, that will also cause hyperkalemia. All these drugs will cause hyperkalemia. As we know, hyperkalemia will cause drug failure, decrease in drug levels, not increase in drug levels. So with this IQ itself, you can just rule out all three options and you can go for clarithromycin. If you want to know the detailed mechanism of clarithromycin, you should know that in GIT, digoxin is absorbed, almost 70% of digoxin is absorbed from the GA flora. The flora, bacterial flora, that will degrade digoxin coming to the GAD. So if you take clarithromycin, which is an antibiotic which will kill the GA flora disturbance will happen. So digoxin won't be destroyed in the GAD at all. All the digoxin will be absorbed into the circulation, causing digoxin toxicity. So this is the mechanism of digoxin toxicity with clarithromycin, and this is how you should rule out to safely go to this option. Next question. A 54-year-old woman with chest pain. In coronary angiography, left circumflex artery was completely stenosed and stenting has been done. She is on medications, aspirin, atenolol, lovastatin, lisinopril. What should be done in this scenario? Add a long-acting nitrate for her, increase the aspirin dose, increase the atenolol dose, add a P2Y12 receptor blocker. What are you going to do for this patient? See, according to recent ACC guidelines, it is suggested that after percutaneous coronary interventions like stenting, you must give dual antiplatelet therapy. Okay, first they were telling for 6 months, now they have extended for 1 year. Minimum 1 year, the patient should receive dual antiplatelet therapy. It can be aspirin with ticagrelor or aspirin with clopidogrel. Since as we know in Indian population, polymorphisms for this clopidogrel is more common. So, and also ticagrelor works more efficient than clopidogrel. So now actually we are preferring aspirin with ticagrelor combination more commonly than this clopidogrel combination. So whatever the question is, the answer will be add P2Y12 receptor blocker. Yeah, the given X-ray is SIRS2 off. Snowman appearance in TAPVC, boot-shaped heart in phalangoastrology, or egg on string TGA, or cottage leaf heart in tricuspid atresia. To see this X-ray itself, you can find the obvious figure of 8 appearance or snowman appearance, which is more specific for supracardiac type of TAPVC, total anomalous pulmonary venous connections. Okay, yeah. Next, if you see this heart, boot-shaped heart, it's very important. As we know, it's seen in tetralogy of Fallot. Tetralogy means the RVH, right ventricular hypertrophy, which will cause the apex, since the hypertrophy is going in the right ventricle, it will cause the apex to shift upward. Okay, so you can find an angle between the diaphragm and the apex. So RV apex will tell. Then if you see the aorta will be enlarged here because there is overriding of aorta happening. Both ventricles are pumping blood into the aorta, as well as aorta is already enlarged in case of TOF. And the pulmonary stenosis will be there, so it's a thin stalk of pulmonary pedicle. So there is a concavity in pulmonary hypoplasia. Then since pulmonary stenosis is there, decreased blood flow to the lungs, pulmonary oligemia will be seen in tetralogy of Fallot. Okay. Next, last, what is this? In TGA, in transposition of great vessels, what happens? From the right ventricle, aorta comes, and aorta meaning it will pump blood with vigorous energy. So there will be pulmonary increased vascularity will be there. And also if you see the string will the vascular pedicle will be very thin, forming a string, and there is an egg on string appearance with pulmonary increased vasculature is common in TGA, transposition of great vessels. A 64-year-old male presented with palpitations for 2 months. On an examination, irregular pulse. Patient has a history of mitral valvular disease. An echo was done which did not show any clot. Most appropriate treatment for him: A. Warfarin, B. Aspirin, C. Dabigatran, D. Aspirin plus clopidogrel. So many will be thinking of dabigatran. Let's see how to approach this question. First of all, atrial fibrillation. I'll tell the brief chunk in atrial fibrillation to be remembered. First, in atrial fibrillation, what happens? The heart rate will be increasing enormously to around 400. Okay, so why it is happening? See, there will be multiple pacemakers originating from the atria. The two around the pulmonary vein origin. When the pulmonary vein drain into the left atrium, there lots of pacemakers originate. Pacemaker means SI node only, but here multiple leaders originate within the atrium. They fire whenever they need. Okay, they fire continuously, but overall rhythm, if you see, due to this irregular firing, there will be irregular rhythm happening in atrial fibrillation. Next, what will happen to the QRS complex? QRS complex will be narrow or wide. See, QRS complex will be always narrow if it passes through the normal conducting system. Normal conducting system is AV node, bundle of His, Purkinje. They are not affected. So QRS will be narrow in these conditions. How will be the P wave? Since a P wave, proper P wave is formed by the depolarization of the right atrium followed by the left atrium, effective atrial contraction. But here multiple pacemakers originate and multiple small contractions happen, small depolarizations happen, forming the fibrillary P waves, or in many cases absent P waves. Okay, so these are the characteristic finding of atrial fibrillation, irregular rhythm. Okay, next, and it won't have, in JP it won't have any A wave because atrium is not effectively contracting, kicks are not happening. Next, how to approach this atrial fibrillation management? See, protocol is a race. You can remember like race protocol. First is rate control is most needed. Okay, rate control is needed because 400 heart impulses are produced, cardiac impulses are produced. If all the 400 is conducted, the patient will end in ventricular tachycardia, ventricular fibrillation, death. So the only system preventing it is AV node. So we should block the AV node more by giving calcium channel blockers, beta blockers, digoxin. How to select the drugs here? First, see whether the patient has any left ventricular systolic dysfunction. If the left ventricle is normal, you can give beta blocker or calcium channel blocker, because if the left ventricle is not contracting efficiently, if there is left ventricular systolic dysfunction, then if you give beta blocker or calcium channel blocker, that will inhibit the myocardial contractility, which is already inhibited more. So that will lead to acute left heart failure. So that we shouldn't let it happen. So in echo, if there is no LVSD, you can go for a beta blocker or a calcium channel blocker. If there is LVSD, then you should only give digoxin, which will increase the contractility as well as it will inhibit the AV node. Rate control over. Next, anticoagulation. How to give anticoagulation in these patients? See, if it is a non-valvular AF, then you should calculate the charge VAS score. Charge is to VAS score. The details you will know. C for congestive cardiac failure, H for hypertension, age 75-65, and D for diabetes. Stroke history will carry 2 points, and VAS means peripheral vascular disease, and sex, females. So all these will carry points. So here if you see, if it is more than or equal to, if it is just equal to 2 in females and more than or equal to 1 in males, there you should going for the oral anticoagulation like dabigatran or warfarin. Always prefer dabigatran over warfarin in non-valvular AF cases, because it has been proved that novel oral anticoagulants like dabigatran, what is the mechanism of action? Dabigatran, TRAN, thrombin antagonist. Okay, direct thrombin inhibitors, dabigatran. Okay, These are actually more preferred because of no need to measure PTNR monitoring for these patients, and they are effective than warfarin in these patients. If it is a valvular heart disease, that too if it is a MS, moderate to severe MS, still studies haven't been done that much to prove the efficacy of dabigatran over warfarin. So if they have given MS in your question, better go for warfarin. That is the option to be chosen. And any prosthetic heart valve disease, there also studies have not been done much. So there also you should go for warfarin. Okay. Remaining everywhere you can prefer dabigatran. C for cardioversion. Whenever if you find a atrial fibrillation patient, you should first check the hemodynamic stability of the patient. If BP is less than 90, the patient is unstable, go shock the patient, DC cardioversion. Or if the patient's BP is more than 90, then you can try these rate control measures. Okay, and if the rate is controlled, then you can go for rhythm control by giving amiodarone, all class 3 antiarrhythmics you can try. Next, last E for echo. Echo should be done because you should see whether left atrium is dysfunctioned. Some thrombus might have been formed due to atrial fibrillation. Since the atrium is not at all contracting, blood stasis happens, thrombus forms according to Wirtz's triad. Okay, so any thrombus is there or not, you should see all these things. This is the protocol which should be followed in any case of atrial fibrillation and how to manage these patients of atrial fibrillation. So the answer for this question is warfarin. Yeah, a 11-year-old girl presented with weakness in the lower limbs. On examination, lower limbs are not palpable. BP in upper limb was 180/110. Dilated vessels around the ribs were seen and X-ray showed rib notching. Most likely diagnosis: a bicuspid aortic valve, ASD, coarctation of aorta, PD. So how to decide this? See, they obviously shown lower limb pulse is not palpable and upper limb BP is high, meaning some obstruction is there past the upper limb vessel origins, leading to decreased perfusion in the lower limb and increased perfusion in the upper limb. Obviously, this is a disease of coarctation of aorta. What happens here is there is an obstruction after the origin of left subclavian artery. Okay, so what will happen? Let's see logically what and all will happen in a egg picture. Okay, first, what happens? The blood flow is increased in the upper limbs because there is stenosis in the distal portion. So blood pressure will be increased in the upper limb. BP will be increased. Blood flow will be increased to the upper limbs. Okay, and also blood flow will be increased to the carotid circulation. That will cause headache. This much increased BP, epistaxis, and even it can form aneurysms in the brain. Due to this increased BP, the media gets weakened slowly and balloon out, forming aneurysms, and the aneurysms can rupture anytime, causing subarachnoid hemorrhage there, or dizziness. All these things can happen. Ischemic attacks can happen. Next, there is an obstruction. So the blood is coming with high pressure and hitting the obstruction. So it will come backward and hit the backward areas, and also it will pass through the narrowed area and it will go and forms a pressure, increased pressure in the post-stenotic area also. So that will cause dilatation pre-stenotically and post-stenotically. So this in iotogram, if you see, this is called 3 sign. Okay, 3 they will say. Post-stenotic and pre-stenotic dilatation of aorta, classical. Next, since there is narrowing, decreased blood flow happens to the lower limb circulation. So there will be obviously radiofemoral delay and decreased blood flow to the kidneys, renal ischemia, activating renin-angiotensin aldosterone axis, resulting in hypertension, secondary hypertension in this patient. Next, so Descending aorta supplies the intercostal muscles actually. Now there is no aorta to supply this intercostal muscles. What will happen now? Collateral starts to form from the subclavian artery to supply these intercostal muscles. This produces dilated vessels around the ribs, and on chronic time it will erode the ribs, causing rib notching. You understood? All the clinical features of coarctation of aorta, we saw it in a single picture. Okay, this is nothing but coarctation of aorta. A patient was treated with a repeated dose of IV antiemetics for his persistent vomiting, after which she developed abnormal movements. What is the most probable treatment for her? A hyoscine levodopa cyproheptadine or benzhexol. So let's see what happened here. See, after giving this antiemetic, which might be metoclopramide, which is a dopamine blocker, the patient started to have abnormal movements. Nothing but a drug-induced Parkinsonism. Usually drug-induced Parkinsonism, if you see, it will appear bilaterally. Mostly it will be symmetrical. In some rare cases, asymmetrical can also happen. Mostly the patient will have bradykinesia more than led by rigidity features. And tremors will also be seen, like resting tremors, postural tremors, or both can be seen here. Next, what are the drugs you can suspect? See, all these drugs cause dopamine blockade. So decreased dopamine causing Parkinson's-like features. So typical and antipsychotics are D2 blockers, as we know. Typical as well as atypical. Typical has more tendency, atypical has less tendency. Okay. Next, if you see antiemetics like metoclopramide. Next, if you see the dopamine depleters like tetrabenazine and reserpine. Okay, all these drugs, if you see, they will just block the dopamine receptor or they will deplete dopamine out of your system. Okay. Next, how to treat this patient or how to differentiate it from drug-induced Parkinsonism and with classical Parkinsonism. See, in classical Parkinsonism, the dopaminergic neurons will always be very less. But here, neurons are there, but the receptors are blocked. So what you can do is, first is you can do a scan which is known as DAT, that dopamine uptake scans. So in classical Parkinsonism, there is no dopaminergic neurons at all. But here if you see, there are dopaminergic neurons which will shine bright after this scan. Okay, you can differentiate it with that scan. Next, treatment, if you see, obviously stop the offending drug. Most patients will improve automatically, but if in some patients you should be giving some central anticholinergic, because in this what happens is dopamine and acetylcholine share a balancing property in the central nervous system. Whenever dopamine decreases, acetylcholine should also decrease, or else this increased acetylcholine will contribute to your resting tremors, lead pipe rigidity, all these features. So you suppress the acetylcholine activity for some time till your dopamine receptor blockade is stopped. You can give like benzhexol, which is nothing but trihexyphenidyl, or you can try with other central anticholinergic agents, and you can try with cinnarizine. All those things you can try with. Okay. Next question. The last structure to be pierced in spinal anesthesia is. It's an easy question. Dura mater, arachnoid mater, ligaments they have given. Obviously, CSF is in the subarachnoid space. So last membrane to be pierced will be subarachnoid membrane. So the layers, if you see, first the ligaments, if you see, first ligament will be the supraspinous ligament, followed by interspinous ligament, followed by the ligamentum flavum. Then you will have your dura, epidural space, then you will have your arachnoid membrane, followed by CSF, your subarachnoid space. Okay, yeah. Next question. A patient presented to emergency department with headache. He has history of chronic ear discharge, left-sided, and pain. A patient present to the emergency with headache. He has history of chronic ear discharge with pain. Most likely diagnosis is they are given a CT scan showing a enlarged lesion over the temporal lobe of the brain, and they have asked simply what is the abscess is located in which part: epidural, temporal, subdural, extradural, frontal, all these things. It's easy. See the abscess location, it's entirely within the brain, parenchyma, and if you see, concentric edges will be opaque, meaning thick walled cavity, vascular cavity is there. Inner it is dark, meaning it is filled with some abscess or some fluid secretions. Yeah, so here otogenic lobe abscess we will tell. Okay, it can be temporal lobe abscess, it can be cerebellar abscess. If it is cerebellar abscess, the patients will have ipsilateral ataxia, nystagmus, diplopia, all the cerebellar features, tremors, all those things will be there. If it is depositing in the temporal lobe, then temporal lobe dysfunction features will be there, like gustatory, olfactory hallucinations, and some psychiatric features also might be seen. Okay, so all these you can expect in case of temporal lobe abscess. You will be giving IV antibiotics. If it's not controlled, then you will be going for drainage procedures. Okay, next. Yeah, a 16-year-old boy complains with purpuric skin lesions in the legs. He had a history of URTI a week before and was suffering from arthritis following that. CBC was normal. Urine showed plenty of RBCs and proteinuria. Following could be the diagnosis spot. So cryoglobulinemia, henoxaline purpura, ITP, or polyarteritis nodosa. How to remember this? This is a favorite question asked every time in NEET. Previous year, every time they are asking this, henoxaline purpura. So what is this disease in short? Actually, you can remember like Shaolin, meaning Shaolin soccer. Kids play soccer, football. So it's the lesion, if you see, purpuric skin lesions, if you see, it will be more common in the legs area where they play soccer, like thighs, lower limbs. The purpuric skin lesions will be there, and they are playing with their legs, so they will develop arthritis with knee as well as ankle joint. This is just a way to remember. I will tell the pathophysiology later. Then since they are playing for so long, you can remember like the patients develop hematuria and melena due to dehydration, so you can remember. But what's actually happening here? See, it's nothing but a IgA vasculitis happening. It's a IgA antibody which is starting to deposit everywhere. First, in response to any mucosal infections where IgA is loaded with, painted with, the mucosa is painted with IgAs. So any infections like upper respiratory tract infections will trigger the formation of lots of IgAs. This IgAs can go deposit in the lower limbs, causing vasculitis and purpuric lesions. Or this IgAs can deposit in the joints, causing arthritis. This IgAs can also deposit in the mesangium of the kidney, leading to IgA nephropathy that causes proteinuria and hematuria, microscopic hematuria, RBC cast will be there. Glomerulonephritis, it is a component of nephritic syndrome. The patients classically have a history of immediately after the URTA, the patient will be having hematuria. This is called synpharyngitic hematuria. Whereas in post-apocalyptic glomerulonephritis, the patients will have hematuria after some 1 to 2 weeks of URT. Synpharyngitic hematuria, it is within 2 weeks. Then if you see, the patient IgA also deposits in the mucosa, GA mucosa, causing melena. All this characteristic tetrad constitutes henoxaline purpura. You can remember like a soccer player. So purpuric skin lesions in the lower limbs, arthritis in the lower limbs, prolonged playing causing hematuria and melena. The option to this, answer to this is henoxaline purpura. Next, a 34-year-old female presented with fatigue, weakness and forearm claudication On examination, pulses were weak and BP is found to be elevated 190-110. In the upper limbs alone, what is the diagnosis? PAN, polyarteritis nodosa, Takayasu arteritis, thromboangiitis obliterans, or giant cell arteritis. So obviously, this is nothing but Takayasu arteritis. How to remember all the vasculitis in short, I will tell you. Takayasu arteritis. Arteritis means some vessel is inflamed. What vessel? Iasus, meaning aortic arch syndrome. Aortic arch is inflamed here. Why? Meaning in young. Less than 60 years patients having aortic arch in vasculitis. You should think of Takayasu arteritis. So what happens here? So aortic arch is getting inflamed more. So aorta is getting stiffened. So aorta's basic action is to have that diastolic pulse by causing that Wincastle effect, by the elastic stretch causing the forward propulsion of the blood column. This is absent here. So the patients will have pulselessness, characteristic feature of this disease. Then if you see, the most common vessel involved here will be the left subclavian artery. Okay, because it is in the turning point. Others are on the flow of the aorta, but it is in the turning point. So left subclavian will be most commonly involved. So what is the classical features? See, since as per the stiffened aorta, the heart is contracting vigorously, overload is going to the heart, so that will can cause angina, hypertension, and prolonged glucose congestive cardiac failure. And also aorta can, due to vasculitis, it can be weakened and dilatation can happen, contributing to aortic aneurysms. If aorta is getting dilated, the root is getting dilated, means the blood coming from the into the aorta will be pumped back into the aorta again, into the left ventricle again. That will contribute to aortic regurgitation. Then blood flow will be reduced in the carotid circulation. That will cause TIA, transient ischemic attacks, giddiness, all these features. Then if you see subclavian artery, it is narrowed. Okay, so left subclavian is narrowed and right subclavian is normal, means there will be BP difference will be there in upper limbs alone. And if you work more, since the subclavian artery is delivering less blood, there will be claudication pain, vascular claudication pain in the upper limbs. BP difference in the upper limbs, warm tenderness in the upper limbs following activity. All these are classical. Then if you see, if it involves renal arteries, there will be renal ischemia, activation of renin-angiotensin aldosterone axis, causing to hypertension, secondary hypertension in Takayasu arteritis. It won't respond initially to common antihypertensives. Okay, these patients are notorious for their BP control. Very hard to control the BP. Then if you see, it can also involve the GI vessels causing melena. Okay, all these are the characteristic finding of Takayasu in a nutshell for you. Okay, yeah, so this patient is nothing but Takayasu arteritis. Next, a 70-year-old female presented with pain in the forehead and pain in the jaw and tongue during mastication and diffuse joint pains. Treatment as first-line therapy: prednisolone, methotrexate, tocilizumab, NSAIDs. See this 70-year-old female, pain in the forehead, jaw claudication pain is happening here. Most specific sign for giant cell arteritis. Here also I will tell from the name how to remember the disease features. First, giant cell. Giant. What is a giant here? First is giant, meaning giant vessels, large vessels involved, vasculitis. Next, what is a giant here? Pathophysiologically, if you see, granulomatous inflammation happens in the large vessels. Granulomas are formed. Next, what is a giant? One more giant here. More than 60 years of age. If large vessels are involved, then it's giant cell arteritis. If it is less than 60 years, it is Takayasu arteritis. Okay. What is the clinical features if these vessels are involved? In GCA, most common vessels involved are the terminal branches of external carotid artery. What are those? Superficial temporal and maxillary artery. So superficial temporal artery is present here. If this is inflamed by vasculitis, it will cause a bitemporal headache for them. And so only we also call GCA as temporal arteritis. And also this inflamed, if you touch it, it will be a tender cord-like sensation because that much inflammation is happening in the vessel. Okay. Next, if you see the maxillary artery, it supplies the muscles of mastication. So usage of muscles of mastication will cause vascular claudication pain, which is the jaw claudication, most specific symptom of giant cell arteritis. Next, facial artery, lingual artery supplies the tongue. So tongue infarction can happen anytime in GCA. If tongue infarction is there, it's must that you should rule out GCA. It's very common in GCA than any other thing. Then ICA, can it be involved? Internal carotid artery? Yeah. Internal carotid artery branches are this posterior short ciliary branches. If they are involved, that will cause vasculitis there, leading to anterior ischemic optic neuropathy, AION. If you have studied in Ofthal, they told that this causes sudden, irreversible and permanent loss of vision. So only if the patient is complaining of all these headaches and blurring of vision, if they say bitemporal region headache, blurring of vision with tender cords in the temporal area, you should instantly you should see the fundus done for the patient. And if you see any signs of optic neuropathy happening, instantly you should start him on steroids. Steroids is the treatment of choice here. That will save his eyes for his lifetime. And how to diagnose? Temporal artery should be biopsied. You know how many thickness they will take? Minimum 4 to 6 centimeter as per Robbins. Why this big length of temporal artery? Because it causes skip lesions here and there. So what if the portion, if you taken, if temporal artery is not involved there, you can't diagnose. So you will take at least 4 to 6 centimeter. And treatment is prednisolone, steroids only. Okay. Interleukin-6 inhibitor among the following is, obviously you would have known because in COVID lots of tocilizumabs we used. Okay, tocilizumab. How to remember? See, well, like you can remember like 6. You can remember like tocilizumab or sarilumab. Sari and tocili both are for interleukin-6 inhibitors. Yeah. A 20-year-old girl becomes anxious and starts complaining of breathing difficulty. ABG showed 7.52 pH, of PaCO2 27 and bicarb of 24, another electrolytes normal. What is your diagnosis? A. Respiratory alkalosis, respiratory acidosis, metabolic alkalosis. It's a direct question. ABG. How to interpret? First see the pH. Is it between 7.35 to 7.45? It is above 7.45, it is alkalosis. If it is less than 7.35, it is acidosis. It's obviously above 7.45, 7.52. So alkalosis is going on. First point we have got. Next, what is correlating with alkalosis? Bicarb more than 24? No, it's 24 only. PCO2, if it is less than 40, yes, it's 27. So it's obviously going towards respiratory alkalosis. Yeah. Mostly in hyperventilation, what will happen? PCO2 will be washed off from the body, causing this respiratory alkalosis. So in that, what also will happen? Since actually in albumin, in the circulation, in albumin, there are proton binding sites and calcium binding sites. So in respiratory alkalosis, what happens is there is loss of alkalosis in the body. So to neutralize those alkali, proton skips from the albumin and it goes to circulation. So what will happen is this areas of albumin where calcium used to bind becomes free. So now calcium goes and binds to the albumin. Ionized calcium becomes low in the body, causing hypocalcemic symptoms like tetany, hypocalcemic seizures. All these things can happen. Paresthesia, tingling sensations, all are hypocalcemic features. Okay, this was also one of the questions asked in NEET. Okay, so let's see to that also. Next, a 7-week-old infant is brought to the emergency with non-bilious vomiting every time he was fed. His mother says stools was pellet-like, abdomen not distended. Likely scenario you would expect in this situation: hypochloremic metabolic alkalosis, hyperchloremic metabolic alkalosis, or hypochloremic metacidosis or hyperchloremic metacidosis. See here, what is happening here? The infant is having non-bilious vomiting, so like some gastric outlet obstruction or something is going on, gastritis is going on, leading to persistent vomiting. So gastric secretions are persistently vomited out. Gastric secretion contains HCl. So H is lost, protons are lost. That will contribute to alkalosis, loss of acids. And chloride is lost. So hypochloremia. So hypochloremic metabolic alkalosis happens. Okay? Yeah. Next. A 43-year-old male patient who is a known case of CKD came with recurrent hiccups and abdominal pain. What of the following ECG, ABG can be expected in this patient? They are given series of 4 ABGs. Let's see what is CKD. In CKD, if the patient is having persistent recurrent hiccups and a severe abdominal pain, means the patient might be in stage of uremic gastritis. So uremic gastritis means uremia features are manifesting. So the stage is already stage 4 or stage 5. That means always in CKD the patient will be in state of metabolic acidosis. In stage 1 to 3, patient will be in normal anion gap metabolic acidosis, and in stage 4 and 5 patient will go for high anion gap metabolic acidosis. Yeah. So metabolic acidosis means what? pH should be less than 7.35 and bicarb should be less than 24. If you see the options itself, see there B and C only has acidosis in the options, and bicarb is less only in the B option. So we'll go for B option. Okay. Yeah. Next, a 34-year-old diabetic female had some food from a nearby restaurant. She has been vomiting continuously after that. She has a BP of 80/60, ABG pH 7.52, sodium 123, potassium 3.1, bicarb 32, chloride 68. What is the reason for abnormality in the ABG? Septic shock, DKA, pancreatitis, persistent vomiting. See, the patient is having what? Alkalosis 7.45 ke upar, so 7.52. So alkalosis is there. And what about the bicarb? It is more than 24. Yes. So it is metabolic alkalosis is going on in this patient. When will metabolic alkalosis happen in diabetic patient? The patient is having some food, and if he is persistently vomiting all the secretions, gastric secretions out, HCl is lost, contributing to metabolic alkalosis. And also they are given chloride is 68 only. Normal chloride should be 90 to 100, less than itna. So that also means that gastric secretions are washed off. So persistent vomiting should be the answer for this. Whereas in DKA, pancreatitis, septic, sepsis, all these things they will be having acidosis as a feature here. The given question is having alkalosis, so it's obviously the answer is persistent vomiting. Yeah, so that's it for the day. We'll discuss more questions out, and we'll have a detailed medicine lecture in Speed Medical app. So don't forget to subscribe the channel as well as subscribe to the Speed Medical app for more Harrison based video lectures in the app there. See you all there. Yeah, thank you.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.